So I'm going to be talking about those weird and wonderful conditions that no one truly understands, and patients can be very challenging to identify, to diagnose, and then treat correctly. These are my disclosures. So we have got used to, over the last few years, using the terms MINOCA, which is myocardial infarction with normal coronary arteries, INOCA, which has already been mentioned already, which means ischemia with normal coronary arteries, and now the term ANOCA, meaning angina with non-obstructive coronary arteries. And I think in the majority of cases, we should use the word ANOCA, because a lot of patients have chest discomfort, but may have an exercise test or a dobutamine or a PET that is negative, but they keep coming back with recurrent episodes of chest discomfort. And if you have a patient that has recurrent episodes, and just because their PET is negative or their MRI is negative, does not mean they do not have one of these conditions. And I've deliberately not included the prevalence or the epidemiology of these individual conditions, because the simple answer is we do not know. The diagnosis of these conditions is made rarely. There is a significant referral bias because we tend to consider these diagnoses in women with recurrent attendances, but tend not to consider them in men, which is a little unusual, where often we tend to test men for ischemic heart disease and not test women. So there is a confusing level of bias that's going on. The principal focus of this talk will be talking about epicardial vasospasm, but there is a phenomenon of microvascular vasospasm, which is also very challenging to diagnose. Sanjog is going to talk about myocardial bridging, and I'll also talk about coronary microvascular dysfunction. And this is all brought in under the umbrella of ANOCA. As we've already alluded to this morning, the coronary vasculature is very complicated. Most of our focus as interventional cardiologists has been on atherosclerotic disease. But there are many patients that have a problem within the function of the vessel itself, and they may have vasospastic disease. They may have issues with the ability to vasodilate. There may not be enough nitric oxide production. And equally, there may be a physical problem with the microvasculature or a functional problem with the microvasculature. Now, all of these things can also be together in the same patient, which makes it even more confusing. Many of the patients who have these conditions will have already had some form of stenting because they've come into the cardiac cath lab, someone saw a mild stenosis, said, okay, you keep having chest pain, I'm going to put a stent in. Let's see what that does. But in fact, on top of that, they may well have all of these issues together, and it can be very hard to unpick. The first challenge is to think of the diagnosis, and the second challenge is to then consider the testing. The testing requires two key drugs, adenosine and acetylcholine. Most of you will be very familiar with adenosine, and that is because you've used it to measure fractional flow reserve, and that is a key component in the assessment of these patients. Adenosine causes vasodilatation of the microvasculature. In the microvessels, there is smooth muscle that is around the microvessels, and adenosine causes vasodilatation of that, which causes a massive increase in flow. In patients that have a coronary stenosis, you'll see pressure loss, but if there is no coronary stenosis, you should see a big increase in flow, and if you use something like either a Doppler flow wire or a thermodilution system, you can measure something called CFR, coronary flow reserve, and you expect to see that to go up. And most people should have a CFR that is over 2, and in many young people, it can be as high as 3 or 4, and incredibly fit people, it can be as high as 5 or 6. Then when we give acetylcholine, what our vessels should do in response to acetylcholine is trigger the release of nitric oxide. Acetylcholine binds the muscarinic receptors in the smooth muscle cells around the epicardial vessels, and it causes them to release nitric oxide, and that should cause them to dilate. This is important. Acetylcholine should cause the vessels to dilate. If there is not dilatation, then there is a problem in response to acetylcholine. So what I would propose to you, and what we try and do in our cath lab, and we're not 100% successful in this, is that when you have had a patient that's had recurrent symptoms of chest discomfort and they come to the cardiac catheter lab, if they have some mild plaque, we will then perform a pressure wire to prove that that is not flow limiting. Once we have established that they do not have flow limiting disease and they have recurrent symptoms, we then want to test for coronary microvascular dysfunction, CMD. And we do that using a thermodilution wire. Now, I've just learnt today that you guys don't have easy access to the thermodilution system, but that's what I would propose that you do when the availability becomes available. And only after you've done that do you go on to do more advanced testing with acetylcholine. There are difficulties in the arrangement of this setup, and I'll talk about that in a moment. And that is because in our catheter labs, we prefer to go radial. And we prefer to go radial because it's less bleeding, less complications, and it means we can get the patient home very quickly after the procedure. And we always give verapamil in the cocktail for the radial procedure. If you have given verapamil, then you cannot test for spasm properly. We also give intracoronary nitrate in every pressure wire case, and that will have some limitation to testing for vasospasm. So what I would propose is that you don't try and do this all in one go. You break this into two separate procedures if your patients and cath lab can tolerate it, and you have an assessment of their coronary vessels first, the epicardial vessels, and at that time you look for microvascular dysfunction. And if it is negative or absent, they have ongoing pain, you then bring them back for a dedicated testing with acetylcholine. And I'll show you how to do that in a moment. So let's just talk about microvascular dysfunction testing. The microvasculature represents a massive amount of the coronary circulation, and we cannot see it. We can't really see it on MRI, we can't see it on CT, we can't see it on coronary angiography, but we get an indication based on blush, and we can test it using thermodilution. The way we do it is exactly like any other pressure wire. We engage the coronary circulation with a guiding catheter, avoiding damping. We give intracoronary nitrates. We place the wire inside the vessel, and we then give normal saline at room temperature into the coronary vessel, and we give a brisk injection through a 3-port manifold. And by doing that, we can make measurements of transit time and temperature change in the vessel, and that allows you to work out the blood flow at rest. We then induce adenosine and give adenosine at 140 mics per kilo for 3 minutes, and then we remeasure the transit time, and that will allow us to measure the CFR and the IMR. The validation of CFR is incredibly strong, and CFR is a very, very strong independent predictor of poor prognosis long term, even if your coronary arteries are normal and unobstructed. IMR, whilst we talk about it a lot, has more modest validation, and although we have an idea of what is normal, we don't truly know what it means to be abnormal. But we get the information, and if there is coronary microvascular disease, then we can tell the patient that yes, you have chest pain. No, there are no major blockages in the vessel. It is to do with the microvessels, and the management of those patients is typically with a combination of ACE inhibitors and statins and aspirin. This is the data that you'll get when you make a measurement like this, and this is the true patients that you are looking for. Patients with low CFR, so a value of less than 2, and high IMR, so a value of more than 25. Typically, they tend to be over 40, and in this situation, they have a generally poor prognosis. They have recurrent chest pain, they have recurrent attendance to hospital, and you have to have a protocol of giving them medications. We give them all ACE inhibitors, all statins, and then we often give them vasodilators, nitrate, nicorandil, ranolazine in an attempt to help them. In the other boxes, it is less clear what the results mean. There are lots of different studies. They all show conflicting results. I would not make any strong statement about any of them. Once you have assessed coronary microvasculature, you then want to assess for coronary vasospasm. This is more common than people think. It is very common in the Far East, but it also exists in Western populations, and I'm sure across the Indian subcontinent. And the way to do this is to infuse acetylcholine. This is a muscarinic activator, and it needs to be infused directly into the coronary artery. In the past, we used to do it using an infusion catheter. We've now stopped doing that for simplicity. And in fact, you do not need a Doppler flow wire at the same time. You simply need a guiding catheter, and we now do this radially using a 6 French system, using a glide sheath to keep it comfortable for the patient, and then infuse the acetylcholine directly into the vessel. Acetylcholine has a number of limitations. In the United Kingdom, it is not readily available. It comes as eye drops, and we then have to reconstitute it in the cardiac catheter lab. There was a time when it was very challenging, and the pharmacists wouldn't supply it to us. We've now resolved that problem, and we have it available in our lab, and we make it diluted into 3 separate dilutions. And we start with low dose, we then go up to the second dose, and then on to the high dose. Almost no patient has any reaction to this low dose. It is almost a waste of time, and some people argue that you can actually ditch it, but we do it. We then run at 20 micrograms before going on to 100. If they have coronary vasospasm, they will react to this dose. When we give the infusion, we connect it wet to wet to the 3-port manifold and infuse it continuously for around 3 minutes. You can hand inject it more quickly. You have a risk of inducing intense spasm if that happens, and you may need to give some nitrate quickly because it can cause a patient a great deal of discomfort. When you are testing for this, it is important to have the consent of the patient directly. The risk of this procedure is low, thankfully, and the likelihood of myocardial infarction on the table is very, very low. Luckily, in our lab, we've not had one yet, but patients do get severe chest discomfort because, as you will see in these little images here down at the bottom, you are inducing severe spasm of the artery, and there will be ST elevation or ST depression at the time. So it's important to mention this. It's very important that if they are on diltiazem or verapamil, that it's been stopped for at least 48 hours before they come into the cardiac cath lab, and we try and stop beta blockers also. And this is why it has to be a planned procedure rather than doing it ad hoc. We've not had much success in doing it on the fly. Also, because it takes time for the nursing staff to reconstitute the acetylcholine, we try and block book these patients in, so we're doing 2 or 3 of these cases at the same time, and we try and do them in the morning when the patient is most relaxed. If you're doing it in the afternoon and suddenly the cath lab is busy, the amount of stress that we induce the patient can also induce spasm without doing anything. This is an example of spasm. It's very clear. Here there is an LAD. You'll notice there is diffuse coronary disease as well, and you can see with the process of acetylcholine, the vessel is highly significantly stenosed. And the addition of glycerol trinitrate relieves that stenosis immediately. These images are shared by my friend Bruce Samuels, who does a lot of this over in Cedars in Los Angeles. And he does this as a routine protocol and finds that a significant number of the women that he treats have vasospastic disease. And the recommendation is you take 2 views for every dose that you give. Be careful when you do the angiogram while giving the acetylcholine, particularly in our manifold system that we have. When we give the dye, you can give a very large bolus of the acetylcholine that's been sitting in the catheter into the coronary circulation. When that happens, intense spasm will occur. So before you do the angiogram, aspirate back any acetylcholine that's lying in the catheter. We make a diagnosis of coronary spasm if the acetylcholine induces chest pain and we see ECG changes of ischemia, and we see very clear spasm. Any spasm of 75 to 90% we would call epicardial spasm. If we cannot see any spasm, but we still have chest pain and ECG changes, we then call it microvascular spasm. And if you are doing it with a flow wire, which we used to, but we've stopped doing now, if there is coronary microvascular disease that's concomitant, there will be a reduction in blood flow as well at that time. There is a special condition that I don't want to dwell on too much, which is called endothelium-dependent coronary microvascular dysfunction. And this is an entirely different disease entity, which is mediated by an entirely different system. This is mediated through reduction in cGMP and apparently responds to L-arginine. I have to say this is very difficult to diagnose, and I would not make any of these diagnoses without using a Doppler flow measurement. And given that this technology is no longer available in routine clinical use, I suspect we'll stop talking about this condition. So at the end of it, we have a number of different diagnoses. Once you've gone through this process, you've done an angiogram, you've shown there's no obstruction, you've proven there's no ischemia, epicardial ischemia by doing IFR, FFR, you've measured the IMR and the CFR, and you've then given acetylcholine, you'll then have these diagnoses. And I'll zoom in, because Sanjog is going to talk about the myocardial bridging. You'll have either a diagnosis of microvascular spasm, which means they have chest pain and ECG changes, but the flow in the epicardial vessel looks normal, or you have true epicardial spasm, where there is a tightening of the vessel, or it's in between, which we call endothelial dysfunction. Okay? Now, having said and shown you all of these things, the question is, well, what do we do about any of them? And the upshot of it is we don't really know, but we generally give diltiazem or verapamil in the first instance, and then we follow it with nicorandil and ranolazine. And this schema will help break down your thought process, and it's very similar to what I've already shown, but it includes the myocardial bridging. And essentially, you can think of the problem as either being in the epicardial part of the vessel or in the microcirculation, and then it's either an abnormal response to adenosine or acetylcholine, and essentially it breaks down in the same way as I've already mentioned. But just to confuse you right at the end, they tend to overlap. And forget all of this gumph around, but this is the key bit I want you to see, that a lot of the patients who have recurrent chest pain will have a little bit of all of this. And so whilst experts in the field will stroke their chins and ponder very widely about the findings, ultimately the treatment we end up giving tends to be the same, except in myocardial bridging, which Sanjog will tell you about. So, ANOCA is an umbrella term for a complex set of conditions which all overlap. We don't have very good data because there is a huge amount of referral bias. The problem has been that we don't tend to consider the diagnosis. I have been as guilty as anyone that we tell the patient, your chest pain is non-cardiac because all the other tests are normal. This is not the case. We should be testing for this on a more regular basis. We do need to build programs for it. You have to find someone in your cath lab who is interested and will consider it. And you need protected time in your cath lab to be able to do this because the testing is complicated. It takes time to build experience, and you need the patient to be in a stress-free environment. So not everyone rushing around them and the doctor shouting or the nurses shouting. Very important. And get experience in diluting up the acetylcholine and standardize your protocols. Thank you very much.